tuberosity of the fifth metatarsal. Most common area for foot fractures. Most common area for foot fractures is that tuberosity. Most common site for fracture, foot fracture. Okay. What side?
Talus.
Are you guys looking up there? I said don't look up there. Okay, this is talus. Anterior to the talus.
Navicular.
Navicular, anterior to the navicular.
Superimposed.
Superimposed cuneiforms. Okay, good. All right, and what is this little monkey down here? Sesamoid bone, right? Because it looks like it's a separation of the bone, but those are your sesamoid bones. By the way, and this is my opinion, I think toes are the most ugliest things. They're just ugly. And then when you look at them laterally, you just look like they're like this, like claws.
Not everyone.
Huh?
Not everyone has those hammered.
Yeah, and not everybody dislikes toes.
I don't like toes.
There's some people who love toes.
Foot fetish?
Major foot fetish.
Yeah. Okay, any questions here,
There are
guys?
some pretty ones too.
Huh?
No. Those are not pretty.
I mean, I've seen some pretty toes, but I still don't like them that
Look
much.
at those toes, they look like Del Taco French fries.
Oh, yeah.
Ew, you just ruined Del Taco
You
French
just,
fries.
you just ruined curly fries for good.
I can't even say I've seen Del Taco French fries. You haven't lived. You go to Del Taco French fries? God, every Wednesday.
Every Wednesday.
Why are they on Del Taco night?
Oh, look, yeah, see, look, they look like French fries.
Wrinkle fries, what?
All right, let's go back to this foot. What position do we have here?
AP. Or dorsal plantar.
Okay. This is an oblique foot.
Oh.
It's an oblique foot, guys, okay? And one of the giveaways for an oblique foot, if it was AP, you wouldn't see the heel. Okay? You wouldn't see the heel because it would be superimposed, okay? So it's in between a lateral and an AP. So first off, you can see the heel, so this is not an AP. But when you're looking at the rest of the anatomy here, especially the metatarsals, okay, there is no superimposition like you would see in a lateral. Okay, so this tells me this is not an AP. This tells me this is not a lateral. Does that make sense?
Mhm.
If it was AP, you wouldn't see the heel. If it was lateral, you would have superimposition of the toes and the metatarsals. Okay?
What's going on with the first?
Is that a break or a fracture?
On the first one, right here,
Yeah.
that's your sesamoid bone.
Oh.
Yeah, it's closely attached to the head of the first metatarsal, so it's very close. All right, what else can we talk about there? Okay, so the oblique position is the best position for evaluating the sinus tarsi. Remember the sinus tarsi? This is the best position for evaluating the sinus tarsi. It is that tunnel between the talus and the calcaneus. So the sinus tarsi is that tunnel between the calcaneus and the tarsal bone. The oblique is the best way to demonstrate that. Okay. Now, again, you guys are detectives, right? Are you guys detectives? Because that's what we do as techs, right? Which way is the foot rotated?
Medially?
How do we know?
First and second.
Based on what?
First and second metatarsal here.
Okay. Well, here's your leg, and it's rotated towards your great toe. Well, yeah, I mean, you guys are all correct, but I'm going to make it simple for you guys. Here's the leg, and the leg is rotated towards the great toe. It's turned this way. I'll show you guys. Never mind. So before you guys started wearing uniforms, and because I've been lecturing this material for a very long time, before you guys started with the uniforms, our students would dress in their regular clothes. So when we began lower extremities, I would instruct the females not to wear skirts. Okay? Why?
Just we're frog legging.
Yeah, your legs are going to be all over the place. You want to maintain modesty, right? So if that was my concern with the students coming in when we practice, is that a concern for your patients when they're flopping their leg inward and outward? Okay? Now when you're dealing with the lower extremity, you have to maintain modesty. Making sure that the parts are covered at all times.
Do you make them like for ankles and stuff? Do they need to take, they don't need to remove pants or anything, right? Just pull
They may or may not. It depends. If you got those really tight skinny jeans now, where it's pasted onto your skin, you really need to pull those things up. If not, you're gonna have to remove it. Okay. The other thing that I want to give you, start advising you guys now is that when we're practicing on each other, okay,
Take showers.
good foot hygiene. Good foot hygiene. Okay.
Everybody better be wearing socks.
Right? And don't forget to wash your hands when you're touching each other's feet. Okay? Just telling you right now.
Great, I'm gonna get a pedicure.
Well, I mean, look, so pretty much we all have pretty good hygiene, right? Now think about patients who have damage to their foot and you're x-raying their foot, who don't have good hygiene.
Mm-hmm.
Bums.
Huh? Like transient or athletes. One of my, when I was working at Anaheim Memorial, it's called Anaheim Regional now, when it was Anaheim Memorial, we were the official hospital for, okay, so I'm gonna date myself. We were the official hospital at that time, the Anaheim Rams. They were the LA Anaheim Rams, okay? You guys know Jackie Slater?
Mhm.
Okay, met Jackie Slater. We were also the official hospital for the Angels and the official hospital for the Ducks. Okay, you guys know Paul Correa? Paul Correa was, he's gonna be inducted into the Hall of Fame, but he was one of the best players in hockey history and also played for the Ducks, young kid. He came into our hospital to have foot x-rays done because he got hit with a very high velocity puck. Okay, and they thought that they broke his foot. So anyways, I did his x-ray. And he took his shoes off, and he took his socks off. I was like, oh my God, dude. What happened here? He had claws. He had claws. And then not only that, but he just came straight from the hockey game, and I'm thinking, oh, I need
It's
a
a little
mask 'cause I'm
funky.
about to pass out. So that's the foot. Now think when you guys are having to do the hip. Where's the hip located? It's near the groin, right?
Buy that junk.
Here's some wipes.
I'm just preparing you guys that
Here's
you
some
may
big
run
ones.
to
Go
some
clean up. I'm gonna go.
odoriferous scents. I know.
Great.
Just take a shower, please.
All right. So are we pretty much familiar with anatomy now?
Yeah.
Okay. Here is an AP projection of the ankle, but it's a special type of projection because we can see opening here and opening here. So what AP projection is this specifically called?
Mortise.
The Mortise. So this is an AP Mortise. Okay. Okay, let's do this. What's A?
Fibula.
Fibula.
Malleolus.
The lateral
one?
malleolus.
Lateral malleolus, okay, or the fibular malleolus. Then F, it's pointing to the bone.
Tibia.
Tibia.
Medial malleolus.
Tibial malleolus or the medial malleolus, all right? You have this
Mortise joint.
Mortise. Okay, so, I heard plafonda. Plafonda refers to the surface of the tibia, so the plafonda is right here.
That's wrong.
Huh? What happened? Oh. Did I say LaFonda?
You said
I said did I say LaFonda?
You said Profonda.
LaFonda, I'm sorry. Okay, so this is the
If you
LaFonda.
give these answers on the quizzes, you can't mark us off.
Fair enough. Fair enough. All right, let's go over here. What's A?
Fibula.
Okay, the fibula. Okay, remember, and that's why I say this over and over again because it's important in critiquing your films. So, in a lateral projection, again, the fibula is going to be more posterior and inferior to that of the tibia. Okay, so it is posterior with superimposition and inferior when compared to the tibia. All right. Now, I'm not quite sure what H is pointing to. What is it? Huh? Mortisis is only on the AP. You're not going to be able to see it on the lateral.
Anterior tubercle.
Anterior tubercle is what it says?
Yep.
Okay, let's go with that. H is anterior tubercle. Okay, what's a tubercle? It's going to have a rough surface, so what are you going to find there?
An attachment.
Either a tendon or a ligament, right? Okay. All right, G.
Sinus.
Sinus.
Sinus tarsi. F.
Talus.
F. Does everybody agree on that? Talus?
Yes.
Anterior to the talus?
Navicular.
Navicular, very good. B.
Calcaneous.
Calcaneous, anterior to the calcaneus.
Cuboid.
Cuboid, anterior to the cuboid.
Tuberosity.
Okay, no. Okay, I'm not talking about D right now. I want to know what's anterior to the cuboid.
Fourth and
Fourth
fifth.
and fifth metatarsals. Okay, now let's talk about D.
That's the fifth. Tuberosity of the fifth.
Tuberosity of the fifth metatarsal. Okay. You guys got the hang of this. All right. All right, so technical and position considerations. This is an older set of slides, so there might be some modifications here. Just like the upper extremities, most of our SIDs are going to be done at 40 inch. At 40 inch. Gonadal shielding. Always get in the habit of shielding your patient's gonads. Just like the upper extremity, you want to use tight collimation. Tight collimation reduces patient exposure, but what else are we doing to our image?
Improving it.
Okay, we're improving image quality, okay? So collimation promotes good contrast, lower densities caused by scatter radiation, that's fog, okay? And when you collimate, you're also going to increase the detail and resolution of your image. All right, correct part and central ray alignment, part parallel to the image receptor, central ray perpendicular to the part and the IR, and then also proper side markers, anatomical markers. Tiffany, did you find your marker?
Yes.
You did? Okay.
I didn't find mine though. If everyone has a left KFK.
KFC?
Are we all hungry or what?
I know, right?
Del
Taco, KFC. Did the students advise to you guys to purchase some additional markers?
Yeah.
I would go ahead and do that now, if you haven't already. Trust me, by the end of the semester, you guys will lose one or both your markers. So might as well get them now. Where do they suggest you get them? On eBay?
eBay's good.
eBay's good? And they got some pretty cool ones there, because they got crossbones and puppies and butterflies.
There you go, Shannon.
Okay.
Go buy some puppies
Yeah.
and cats.
Do you guys know what Mitchell markers are?
No.
Okay, the markers have an area in where you have, I won't say free-floating BBs, but there are BBs embedded in the marker. And they kind of move around based on the position of your marker. So if you did it flat, okay, if your markers were flat, the BBs will fall right in the center of the container of those BBs. If you did an upright position, you will see that the markers will be lower in that circular area that contains the BB, so you would know if that was upright. It also helps if you're doing decubitus films just based on where those BBs are located. You spend a little bit more, but they're really cool to have.
They're $37
For what?
for what you're talking
Is it
You know what I'm
about.
talking about?
How much?
Oh, like the ones that.
$37?
You on Amazon, Kristen?
Amazon.
For both? Is that 37 for both?
Yeah.
This is a Mitchell marker. So you guys can pass this around, but there's BBs located in the inside of your marker. And again, based on the location of those BBs, it'll tell you if it was done flat or in an upright position. Just pass that around. And I think if you buy them in bulk, they're cheaper, right? So buy like a set of 50.
50?
And some everyone
Yeah,
else?
and then just, yeah.
And then just up the price?
How do you get them personalized?
Yeah, I think you can buy them in bulk, so they're cheaper if
That's
you
what our
buy
dues
them.
with our 2 markers and not a bag.
Right.
There's like a set of labeling markers also, you know, for supine, lateral, all
Right.
that. Is that worth investing into
Right.
later?
Probably not.
Because a computer, you can do that, right? You can label with the.
Yeah, because now you can annotate. What's more important is that the markers have your initials on there, or some kind of identification that says that you're the person who took the X-rays. Okay, but that's the important part of it. Okay, so proper side markers. Technical considerations. Lower extremities are going to be slightly thicker and more dense. Lower extremities are going to be more slightly thicker and dense than that of the upper extremities. So now our KVP is going to go up a little higher. Short exposure times to minimize what?
Motion.
Minimize motion. Small focal spot. What's the small focal spot for?
Better detail.
Okay, better detail. Okay. Cross out detail screen film since we're not dealing with film anymore, so cross that out. Adequate mass and application of grids for over 10 centimeters. So guideline is that anywhere up until the knee, so your tib fib, your ankle, your foot, your toes, you generally won't need a grid. Once you reach your knee, now you're probably gonna have to use a grid. Okay, so knee up, grid. Okay. Okay, positioning considerations, remove footwear. Our imaging systems now are very sensitive, and so even, it can also pick up now the fabric. So if you're wearing a sock, that can also be shown on the x-ray, and it may interfere with identifying hairline fractures. So remove shoes, remove socks, remove any type of body jewelry. Okay? Shielding. Get in the habit of shielding your patients. Modesty. Now the legs are going to be flopping all over the place, and as I will show you guys later with our images and how to acquire those different radiographs or images, you're going to need to make sure that your patient is covered at all times. Patient instructions. Are we going to have our patient hold their breath? Okay, simply we're just going to tell them to hold still, don't move. Okay, hold still, don't move. All right, I'm going to have you guys just review the alternate, okay, the other modalities.
Alternative.
Thank you. Okay, we do arthrography to evaluate the joints. Okay, when you guys start your clinical internship, you will see a multitude of arthrograms. Arthrograms are generally done with synovial joint spaces. Synovial joint spaces. So we're talking about diarthrodial synovial joints. Okay, so these are conducted for the shoulder. What else? The knee,
Hip.
and the hip are the most common places. Okay, there's also a wrist arthrogram. However, they don't do that as much as they used to because the bones are so small, hard to evaluate the joints. So what they will do is, it's considered a special type of procedure where the doctor will go in with a spinal needle, okay, inside the joint space. They will extract some synovial fluid. They will send that synovial fluid to the lab for analysis to find out if there's any type of disease process. And then they will replace the synovial fluid that they extracted with contrast. Okay? We're trying to maintain the same type of volume within the joint space because if you injected contrast into the synovial sac, it's gonna be very painful. Okay, so we try to maintain the same amount of volume by removing the fluid and replacing it with contrast. Okay? Now, as technologists, once the contrast is injected, you're gonna be taking a multitude of x-rays in different positions. Okay? So this is an arthrograph. So the doctors may do it under fluoroscope, or you may do it as a technologist on your own. CT is the most common way of evaluating joint spaces now, okay? Because x-rays are good for bones, not good for joints. So if we're evaluating the joint, it may be done either by CT or what's the other modality?
MRI.
MRI, okay? And did I mention that hospitals play the political game? Okay, even when they know what's wrong with you, they're gonna start with the basic examinations first. So you won't go immediately to a CT, you won't have an MRI immediately done. It may be weeks and months until you get that done. But then meanwhile, they're trying to milk you for as much as they can by doing the most basic type of procedures first, okay? So even if they know it's a joint issue, you're not gonna have a CT or an MRI for a very long time. All right, bone densitometry is another type of modality that they use, and it's simply just that. It measures the density of the bone. It's a special x-ray equipment. It does use x-rays to evaluate the calcium content of the bone. This is generally done with older patients, or those who have osteoporosis, or some kind of bone pathology. Nuclear medicine is another way to study bone pathology. Not a good way to study bones itself, but this is a study of metabolism. This is good in detecting cancerous process. Now, did we talk about nuclear medicine before, or do you guys have an idea of what nuclear medicine is? Okay, so in nuclear medicine, we are injecting our patients with the radioactive pharmaceutical, so now they become the source of x-rays rather than us providing x-ray to get the image. So unless you're not used to looking at a nuclear medicine study, it simply looks like just a bunch of dots. Okay, but those dots, when they translate into it can translate to where there's a disease process that may be occurring. But I'm not going to spend too much time on that. But nuclear medicine, again, it's your body who is emitting the radiation. All right, let's take a 10-minute break, and then we'll begin with positioning, okay? Let's do a 10-minute break.
It's all good.